Hi, it's Dr. Centeno, and thanks so much for joining me today. Got an interesting topic. Normally I try to see what's out there, see what questions I'm getting asked over and over again. And one I think that comes up a lot, especially when I'm doing telemedicines for CCI patients, is the topic of quinolone antibiotics or fluoroquinolone antibiotics and ligament damage, meaning that I require patients to have a reason for why they got craniocervical instability, whether it be trauma or HEDS. And sometimes the reason I get is, well, I got Floxed. I took these antibiotics and everything went downhill after that. Now, we know a lot about quinolone antibiotics and tendons. And probably about 2 or 3 years ago, this first came up. So I looked it up. I said, well, maybe there's a whole bunch of literature out there on quinolone antibiotics and ligaments now. Turned out I could find very little. So I wanted to bring this up because, there are lots of reasons why someone may have, for instance, craniocervical instability. Maybe a long time ago, they had some sort of head trauma that they kind of wrote off when they were younger. There's things like that. But I think we also have a tendency to want to blame our problems on something, right? And I think sometimes that something becomes quinolone antibiotics. Sometimes it becomes some sort of infection, et cetera, et cetera. So let's dig into this. Let's see what the medical research shows and what it doesn't show. And then, as usual, you can ask questions about this topic. You can ask questions really about any topic at all. So let's dig into this. Again, if you're just joining us now, I'm going to talk about can ligaments be floxed? Is there this relationship between quinolone antibiotics and ligament damage? And again, if you have any questions, just type them as you think of them in the comments section on the platform that you're on. And I'll get to those right after a short lecture, 5-10 minutes on what I found on this topic of ligaments and floxing. So let me go ahead and share my screen here. And then we're going to go ahead and start this presentation here. So this presentation is going to be on, and the topic for today is, can ligaments get floxed? What's the evidence behind fluoroquinolone-induced ligament injury? So there is a significant body of evidence that quinolone antibiotics, things like Levaquin, ciprofloxacin, can cause tendon problems. And that's been fairly well known. The literature is not perfect, but I think it's strong enough for us to say that there's this relationship, and we should be cautious as doctors in prescribing these quinolone antibiotics. And if someone starts to have tendon problems when they're taking these drugs, the drugs get stopped immediately, et cetera, et cetera. And we've had a lot of good success in treating those patients with PRP injections into the ligaments, or I'm sorry, into the tendons. But a tendon is not a ligament, and that's important to understand. And I think this confuses patients sometimes. So we see here off on the left that a tendon is when you've got a muscle that attaches to a bone. And that attachment point, that fibrous attachment point that attaches a muscle to a bone, is called a tendon. Off on the right, you see ligaments, and same joint here, just elbow for an example here. You can see all the ligaments. Now, ligaments are totally different. They're made of different stuff, even though it's a little bit similar to tendons. And ligaments actually attach a bone to a bone. So ligaments normally surround joints and provide stability in a way that tendons do not. Now, tendons can also be involved in the stability equation, but they're not primarily involved in stability. They're primarily involved in helping a muscle do its thing to move our skeleton around. So again, a tendon is not a ligament. So that means that we have to look this one up separately, right? We can't rely on the information that quinolone antibiotics cause tendon problems and say, well, that's the same thing as a ligament and they're all the same, because they're not. So there's a difference between what we have evidence to support and what's on the internet. And I cannot emphasize this enough. In fact, this is even getting worse now that we have these generative answers coming up using very, very simple AI, meaning we're nowhere near artificial general intelligence. That's coming, but we ain't close to that yet. So we've got these dumb algorithms that are throwing out answers, and we're seeing people use ChatGPT to create these answers. I've got it turned on in my Google search, so it comes up every time I search something. And regrettably, it's still pretty dumb, right? It's taking the Google results and it's assuming those Google results are actually accurate. And so here's an example. I searched ligament floxing, right? I've also searched this other ways, ligament, quinolone, toxicity, etc. Now, the first one has nothing to do with ligaments at all. It actually has to do with tendons. The second one is a guy who had multiple tendon problems. The third one is a clinic that talks about ligament and tendon injuries induced by fluoroquinolones, but doesn't have any evidence to support the ligament statement. Now you can see the answer off to the right there that Google generated because of these three hits, none of which really scientifically have anything to do with ligaments. So I got the wrong answer here from Google when I looked this up. Now, there's a medical research mantra that I've always loved. It's what do we think, what do we know, and what can we prove? What do we think is, as a doctor, I observe certain things, right? So I may observe some patients who tell me that they took a quinolone antibiotic and it messed with their ligaments. Now, the what do we know part would be, I've had 300 patients walk in the last 10 years that clearly relate taking a quinolone antibiotic and a ligament problem. And then the what can we prove would be, and I've done a randomized controlled trial where I took a bunch of people and we gave them quinolone antibiotics and other people got a placebo, and the people getting quinolone antibiotics had a heck of a lot more ligament problems. And we then determined what that mechanism was, let's say using lab data. Now, this is the research that's out there on tendon and quinolone toxicity. Good amount, 422 papers. Some of these are about other things, but a good chunk of these are going to be about tendon toxicity. So for quinolone and tendons, we're between this, what do we know and what can we prove? We don't have a lot of randomized controlled trials that have been done to prove this. But there's a really strong connection here, strong enough where most doctors would say, yeah, there's a relationship between these two things. Now, regrettably, this is all I get off the US National Library of Medicine when I put in ligament fluoroquinolone-induced toxicity or some version of that. I basically get 3 hits. Now, the hit that I didn't show you, there's actually 4. Actually postulated the other relationship, that in ACL healing, taking ciprofloxacin helped the ACL heal. So I didn't include that one. I only included the ones that seemed to point the direction of maybe fluoroquinolones causing ligament toxicity. So let's look at these. The first one is really just a lab study, right? It seems to show that both quinolones and steroids can have a negative effect on human ligament cells. But it's just a lab study. It's not a clinical study. It doesn't involve any patients. It's just throwing some of those cells in culture and then adding these things and observing what happens to the cells. This one actually is a lab study as well, but doesn't use human cells. It uses rabbit cells that are derived from the ACL ligament. So again, another lab study. It's not even in humans. And then we've got a single case report. There's 2 patients described here, one that had tendon issues after taking ciprofloxacin, another that had a ligament issue after taking Cipro. So this is the only human clinical data that's out there. That's it. So we got 2 lab studies, one that uses human cells, one that uses rabbit cells. We've got a single case report. So that's far different than studies designed to see if this relationship exists. So there's almost nothing to support with regard to clinical studies that fluoroquinolone antibiotics cause ligament instability. And there's certainly nothing to support that quinolone antibiotics cause craniocervical instability. So where are we with quinolone and ligaments? We're still in the what do we think phase, right? Could be that more data comes in that moves us down this line. So it could be that at some, at some point, maybe more clinical data gets published in the future that shows that ligaments are impacted by quinolone antibiotics, and we get some good clinical data as well that makes that connection stronger, but we're not there yet. So when I tell you during a telemedicine, for example, that, and you think that your CCI was caused by taking Cipro, I'm going to tell you what the data says right now. And I'm going to say, you know what? We don't really have data to support that. Let's see if we can dig deeper and see if there's another connection in your past that might have caused this CCI. And that would be a reasonable thing to do if you look at what the science currently says, meaning the science is not there yet. May get there, not there right now. So let me stop the sharing and we'll go on and answer. I'll go on and answer some questions here. We got a bunch of them as usual. So let's get those going. Hi, Doc. I've begun to incorporate rolfing. Is icing a good idea after or better to allow the body to heal? You know, in general, I think what I would do is just allow the body to heal. I don't think that you need to add in ice unless you really are having a hard time with it. There's some research that's just starting to be discussed that the RICE concept, the rest, ice, compression, elevation that has become common in orthopedics may in of itself be causing injury or a lack of full healing. Because as you bring up, normally these things go ahead and take care of themselves through inflammation being a part of that healing process. So I'd recommend staying away from ice if you can. It's been advanced by Daniel James. If you have an abnormal amount of rotation between 1 and 2, as noted in rotational CT, what would you think needs treatment? Yeah, so Daniel, I generally don't use rotational CT as an indicator for craniocervical instability. Why? Because we don't have much good research showing that it should be used that way. Now, we do have some research by Dvorak. It's a 1987 paper that shows that if you have more than 56 degrees of rotation between C1 and C2, then that's a problem. But that's not the number that gets used. The number that gets used is normally 40-something degrees as being abnormal, and that doesn't really have any research behind it. It seems to have been picked out of thin air by some neurosurgeon a long time ago who wrote a book. The real number is 56 degrees. So I can count on one hand, after seeing thousands and thousands of CCI patients, the number of patients who had more than 56 degrees of rotation at C1, C2. So I think this is a red herring. Now, there are other ways to get to, is there craniocervical instability that are better studied? The C1, C2 overhang is better studied. Flexion extension, MRI is better studied at this point. So there are different ways to get there, but regrettably, this isn't really a valid one for most situations. Now, I know there's a lot of neurosurgeons that use this, but again, I've tracked down where did that number come from? Where are they getting this 40-some degrees? I think it was 46 or something, that show that if you were more than that, you were unstable. And again, it's not based on research. It's based on some opinion of a neurosurgeon who put it in a textbook a long time ago. I think it comes actually from the Clinical Biomechanics of the Spine, the 1976 edition by White and Punjabi. And there is no reference in there scientifically for where they got that number. Amain, a specialist did AI CCI measurements on my imaging, and none of them show possible CCI. Can my neck kyphosis and lower cervical instability be the cause of my symptoms? Amain, I wouldn't trust most spine specialists to understand what is or isn't CCI. So I don't know how to answer this, meaning that this is a highly specialized area where most spine surgeons are not going to understand what these numbers should or shouldn't be. So it's impossible for me to answer this because there's a high likelihood that whatever specialist looked at this didn't get that right. Now, if you're telling me that you saw one of the 5 surgeons around the world that does this and they state you don't have CCI, then I'm going to put more credence on that. And then, you know, we'd have to go back to the starting gate, if you will, to relook at everything to try to see if there are other causes for your symptoms. Also realize, and it's important to realize, that there's craniocervical syndrome and craniocervical instability. So you can get all the same symptoms by having issues coming from the upper neck without any instability, and that's craniocervical syndrome. I've talked about that here a number of times, so you may want to go back and find one of those videos. Marcia, hello, Dr. C, doing AO for a year now, holding for 2 months, but I feel better, less brain fog, dizziness when I'm out, although on imaging it really looks better when I'm in. What to make of it? Not quite sure what you're saying. So you're doing AO for a year, holding for 2 months, and you feel better. So my sense is if you feel better, that's really where you're going to want to put your eggs in that basket, right? If someone's saying that the imaging doesn't look quite right, you might be out, but you feel great, I would probably not go back to that provider, meaning that those measurements are only important when you can prove they're associated with symptoms. And how do you prove that? Someone's out on the imaging, they feel awful. You correct it, they're in on the imaging, they feel great. But if there isn't that relationship, I wouldn't worry about it. Regenetics, mid-advanced by Daniel. If there's fluid in the C0 joint, C01 joint, so physicians name joints by 2 levels. Sometimes chiropractors will name joints by 1 level. So it would be the C0, C1 joint from an injury. Should the fluid be drained prior to injecting it? Is there a risk for injecting into it and causing head pressure? Are you aware of excess fluid in this joint? Will you use less PRP to try to mitigate unwanted side effects? Yeah, Daniel, a lot of it depends on the amount of fluid. If it looks like there's a large effusion, which is pretty rare in that joint, then yes, we'll try to drain that fluid out just like we would a knee before putting PRP into it. Again, just to give you a caution here, with 0-1 injections, that's a Colorado only injection. We don't refer anyone out for those procedures. It's a very difficult procedure to perform. It has to be done under fluoroscopy with contrast confirmation and digital subtraction angiography to be done safely. So again, if you're talking about getting it done somewhere else, we don't recommend that. It's too high risk and too high a risk to your personal health. Casey, in one of your blogs, you mentioned your niece with HEDS responded better to Prolo than PRP for her treatment. Was curious as to why. Yeah, so she's got a fairly rare collagen 10 deficiency. Now she knows that because she got full-on genome sequenced. She was a grad student at the time at Cambridge, and they offered that to her, so she took them up on it. And so that could have to do with her very specific collagen deficiency, which is very different than most hypermobile EDS patients. It's been advanced by Daniel. If there's only damage visible in the left C0, C1 joint, will you only inject left one, or will you inject both? Realize, Daniel, that we use 3 different tests in order to decide which joints to inject. The first test is going to be what it looks like on imaging. So that's the effusion, meaning swelling in the joint we talked about. The second test is going to be, is it tender on physical exam? And that joint needs to be palpated left and right. Obviously, if they're both tender, we may treat both. Then the third test is, are there referred symptoms consistent with that joint, which is going to be pain in the back of the head. So if all those 3 tests tick off, then both joints will get injected. If some of them tick off pointing at both joints, then probably both joints will get injected. Jessica, when should we stop taking anti-inflammatories prior to PICL? If you're talking about non-steroidal anti-inflammatories, then you would want to stop those a good 1 to 2 weeks before that procedure. If you're talking about supplement anti-inflammatories like curcumin, staying on curcumin would be fine. Fish oil you'll have to get off of, not because of its anti-inflammatory effect, but because of the fact that it seems to thin the blood and it increases bleeding times. And you want to be off of that for a good week or 2 as well. Now, you can go back on those things like fish oil right after the procedure. For non-steroidal anti-inflammatory drugs, you're going to want to stay off for that first 6 weeks or so, because we don't want to blunt that inflammatory response. We want as much of that as we can get. And then you can talk to your individual doctor about whether or not it makes sense to restart that for you to get a baseline. El Zaid, hello, doctor. I want to ask you about the news of the treatment of myositis in the world and what doctor gives the corticotherapy a day. I don't understand the question. We don't use high-dose oral corticosteroids, which is what I think you're describing here, at all, because it's really an awful thing to do to a patient. Now, there might be rare instances where you need to give that. So if you had fulminant myositis, for example, and that were biopsy determined, not just someone's diagnosis, or if you had, COVID-19 and you were trying to save someone's life and trying to improve their respiratory function so they didn't have to go on a ventilator, those are all great reasons to give someone a very toxic drug, which is corticosteroids. But for the vast majority of patients, we don't recommend them taking oral corticosteroids at all. These are highly toxic drugs. They poison the stem cells within your body. They also dramatically increase the risk of a bone disease where your bone turns to mush called osteonecrosis in a dose-dependent fashion. So we generally don't recommend oral corticosteroids unless they're being done to save someone's life. That makes all sorts of sense. Or there's some sort of firm endpoint, like if I don't give this guy oral corticosteroids, he'll show up in the ER 18 times in a month getting treated for his asthma, for example. Then that might be a reasonable gambit as long as you discuss with the patient, hey, if I give you this stuff, your bones could turn to mush, and do you want to continue it? That kind of stuff, that type of expanded consent. It's been advanced by Daniel. On MRI, if the space to reach the alar transverse ligaments looks tiny, what do you do? Are there patients you can't help because there isn't enough space? You can typically find a way to get treatment. Yeah, so Daniel, I would say in my hands right now, about 99% of the time we can get where we need to go. Even if there are bone spurs, we can go around those bone spurs, come up with some sort of strategy there. About 1% of the time that limits our ability. So we might treat below only because we can't get in above because the bone spurs are large enough there. But I would say that it happens so rarely at this point, it's probably not something to worry about unless we know that you've got huge bone spurs on imaging, like maybe on your CAT scan, and we can see those. And since that's a 3-dimensional image, hopefully we can plan, or even CBCT would show that. And we can use that 3-dimensional image to plan with you. Is gabapentin okay prior to a PICL? Yeah, just realize that those sorts of drugs will increase anesthesia requirements, which increases anesthesia risk. Having said that, if gabapentin is making the difference between you being able to function and not function, then you can stay on it. Now, if gabapentin is a drug where you're like, I don't know if it helps at all. I mean, I started taking this and I didn't really feel much different, and the doctor just kept giving it to me. Then you may want to get off of it or talk to your doctor about getting off of it prior to the procedure. Raj, hi doctor, wanted to follow up on rhizotomy procedure for neck facet joint pain. There was a procedure where they cut the nerve near the joint and not burn it. It's also told to target the sensory nerves. Yeah, Raj, I don't believe that for a second. So I have yet to see anyone who can target just the sensory nerve. And even if you could just target the sensory nerve, you still have all sorts of problems. What Raj is bringing up is that most rhizotomies, radiofrequency ablations, radiofrequency neurotomy, there's lots of different terms for this, are done using a procedure that's X-ray guided where the tip of a probe heats up to burn away the medial branch nerve that both innervates the joint and innervates the stabilizing muscle. So if you kill off this stabilizing muscle and you've got instability, that's a bad day for everybody. Now, there are some surgeons that claim that they can go in and do a surgery to kill the medial branch nerve. Number one, it's way overkill, meaning that the surgical retractor time itself will kill the very same muscles we're trying to preserve by trying to go in and only get the sensory component. We have no data on that, but we do have data on retractor time in spinal surgeries being directly related to the kill rate of these small stabilizing muscles called multifidus. So it would be a very dubious claim that by using retractors and putting pressure on muscles that kill muscles, you're going to go into a procedure that's going to save the muscle. Get it? Kill muscles with retractor, save muscle with the procedure. Doesn't make common sense. Then even if you could do it, you've still got a joint that has no feeling, which means that that joint is going to wear much, much more quickly than if it had feeling. So all around, there isn't much rationale in my medical opinion for doing rhizotomy surgically or doing radiofrequency ablation or neurotomy non-surgically. They're both nonsensical procedures, in my opinion, that should be avoided in 2024, especially in patients that are unstable, because we're going to make the instability worse. Cremology, hit the like button, share out, push the doctor up the algorithm. Yeah, I should say that. I don't say that enough. On YouTube these days, everyone says that, right? Like, share, subscribe. I do want you to do that. I had forgotten to say that, so thanks, Cremology, for bringing that up. Like, share, subscribe, because that is how we get this information out to more people. If you don't do that, then this doesn't really get out to other patients. So if you want to give back to other patients, and I know many of you do on these discussion groups, right? You're there to help other people, not only yourselves, in these discussion groups on Facebook and elsewhere. Like, share, and subscribe this, or subscribe to this channel, because that pushes this up and gets it to more people. So thank you for bringing that up. I had forgotten myself. Jessica, do you believe an activator used by an upper cervical chiropractor could injure ligaments? I think it's very unlikely that an activator used by an upper cervical chiropractor could injure ligaments. Regenix, mid-advance by Daniel for rotational CT shows C1 displacing the top of C2 and viewing 3D reconstruction. No, we've got no data that shows that. Now, there's a fairly complex way to try to discuss the amount of uncovering of the joint, and that has a little bit of information starting to support it. It's 55% is the cutoff. But there you've got to actually measure with the 3D reconstructs the amount of the joint that's uncovered in that rotation. which is not being done. I see a lot of eyeballs, especially in the European clinics, saying, well, the 3D reconstruct shows that that joint's a little bit, looks like it has a little bit too much pushed out there, so I'm going to call that instability. So again, we do not use that method at this point because the 3D reconstruct requires you to measure the surface area of the joint that's covered, the surface area of the joint that's uncovered, and do some division in order to get to, is it greater than 55% uncovered? And no one's doing that. They're just eyeballing it. So we do not use that method at all to determine if you've got CCI. I don't believe it would be a reliable method at this point to determine if you have CCI. Daniel, hi, Centeno, what ligaments do you inject when you treat a 1C instability? That seems to be my main problem, worse than extension. Yeah, Daniel, there's a video on that. So I'd encourage you to go look at that video. There's two components there. The first component is going to be, is the 1C symptomatic? In which case is it symptomatic inflection or extension, which will determine specifically what ligaments we inject, what those ligaments look like, what the other measurements are. For example, here we'd be looking at translational BAI on flexion extension MRI, which is upright. So I'd encourage you, come into the clinic, we'll look at all that stuff, or get on telemedicine, we'll look at all that stuff and we'll make some decisions. Jessica, what's your take on craniosacral work? I think if it helps, keep doing it. I don't really have a strong opinion of it either way, but I think if it helps, keep doing it. El Zaid, in the biopsy results, is myositis. How can a person know which type of myositis we have? You know, El Zaid, or El Yazid, I think that's something you got to talk to your treating provider about. I don't want to second guess anybody. And it's a little bit outside of the realm of our conversation here today. Can we have a replay? Yeah, all of this can be replayed on Facebook or YouTube. So once I'm done with the live, there'll be a video. You can replay it from the beginning. Tasha, I'm 16 days post-PRP for cervical spine and sacrum. Is it normal to still be having inflammation be flared up? It's possible, Tasha. What that would generally mean is that you're a fragile leg patient. So that means you have central sensitization or high levels of systemic inflammation. And that's something I would reach out to your doctor about so that they can work with you on that. But it generally means that, like I said, you're in that fragile leg category, or you have high levels of systemic inflammation. And then the doctor is going to want to make sure it's not due to something else as well. It's been advanced by, I wish I could say that name, but I don't have the ability to. Wojciech. My mom's last name was Wojcicki, and I should be able to say that name because I'm part Polish, but I can't. Is it possible to get affected by CCI as a result of sinusitis? No. For a few cases where people begin to have CCI symptoms after sinus infection, one of the American doctors treating CCI claimed prolonged sneezing and forcing neck muscles while breathing while being affected by sinusitis creates similar damage to ligaments as whiplash injury does. I don't think we have any data to support that, nor would it make too much common sense. Now, is it possible to have sneezing in general cause injury? Sure, you can tweak things when you're sneezing. People tweak their backs and necks sometimes when they're sneezing. That's pretty low likelihood, but you could come up with a mechanism maybe of why that would happen for a minor injury. But as far as craniocervical instability, no, I don't think we have any data that points in that direction at this point, nor would it make common sense. And again, I think you've always got to use that common sense test in medicine, right? Does it make common sense? Meaning, how many patients do I see that come into the office that say they think sneezing caused their CCI? I don't think I've seen a single one to date. And I've probably looked at more either CCI or potential CCI patients at this point than almost anyone else on earth. Maybe there are Other doctors out there, maybe some of the surgeons that do a lot of CCI works, have seen as many, see as many on an annual basis, but it's not common at all. So that would tell me that it's probably not happening. Bo, NAD plus helps with pain. Is it okay to take NAD plus injections pre and post PICL? But we don't have any hard data that NAD plus helps with pain. And this is something I'd encourage all of you to do, because I want to teach you how to think analytically and not in terms of Facebook, right? You know, Facebook can be great. It can be great because of groups where you get together with other patients and you talk about what seems to work, what doesn't work, what your experiences are. That's a wonderful opportunity that didn't exist 10 or 15 years ago. But where it can be a big problem is, and there's tons of people on Facebook pushing an NAD+. So let's do it right now. Bo, let me teach you how to think here, because teaching a man how to think is extremely important. So we'll start with good old Google, right? Dr. Google. And instead of asking Dr. Google, because the results are going to be polluted by NAD sellers, I'm going to go right to PubMed, right? So I'm going to type in Entrez PubMed. You can see it up there, hopefully, Entrez PubMed, which is how you get to National Library of Medicine. So PubMed comes up. You could probably also just search PubMed. And then we've got PubMed up, right? So now we're going to type in NAD plus randomized pain. So here's one. So let's see what they say. Review includes 10 studies. Graves is really not what we're talking about, right? This is Parkinson's disease, overweight, postmenopausal prediabetes, Alzheimer's disease. Doesn't really look like it's something that is going to be of interest for us for musculoskeletal. So maybe we'll add here, we can add here cervical, since that's what we're talking about. So whiplash associated disorders, that's just a practice guideline. That's not going to help us. That's another practice guideline. Yeah, so we don't have any information at all in any randomized controlled trials that NAD plus does anything for neck pain. So this is how to think. You don't want to get in the habit of the Facebook think. Again, Facebook, great tool for coming together, but there are more NAD plus sellers on Facebook than I think anything else, because it's a high profit margin game right now. So let me stop that. We'll go back to questions. Charmaine, last week you briefly mentioned 9th type of CCI. Would you please elaborate? Yeah, I don't include vertical instability. You could state that that's the 9th type of CCI. I think it also overlaps with things like type 1C, but you could include vertical instability, meaning where the instability is pretty much all vertical. The problem is it overlaps with any type of type 1 instability, 1A, 1B, 1C, and 1D. So I didn't include it as its own separate type, but I think some of the surgeons would include it as its own separate type. So that's why I mentioned it. Oli, I took amoxicillin for H. pylori. After that, I got all symptoms of CCI. Is there any relationship CCI and amoxicillin? None at this time, no. Oli, again, be careful, right? I think I see people searching for associations, but, you know, for example, hypermobile EDS patients just suddenly randomly start getting CCI symptoms without trauma. Or another example would be someone who had trauma a long time ago, who doesn't really have any symptoms, gets to that point where the wear and tear gets to the tipping point. And tipping points are very important in biologic systems. So eventually that starts to hurt. For example, we all, if you're older, have the experience, right, of a knee that you injured 25 years ago. And then it was fine. You never really knew there was anything wrong with it. But as you get into your 50s and 60s, that knee starts to hurt. It has developed osteoarthritis. It tips over into the fact that it's probably had asymptomatic mild osteoarthritis for years, and that becomes clinically significant. In that case, I'm not searching for some drug I took that might have done it. I'm not searching for a mold infection that might have done it. That's just common sense and biomechanics of why that joint suddenly starts becoming painful. So I think many of these things fall into that category. Facebook user, I may stop answering these if you don't expose who you are, but I'll answer this one. Is there any mechanism of action that quinolones have that is part of the fibroblast process, i.e. good bacterium involved in connective tissue building? We don't know, and we don't know is the answer, meaning that we have the 2 lab studies that look like they could be on the same plane to what it is we're talking about. One with human ligament cells, the other with rabbit ACL cells. And they seem to show that there's some relationship in the lab there, but how that extends out to actual real life is anyone's guess at this point. It's been advanced by Sherry Scott. So for us to have CCI, for a regular doctor prescribes that medication for infection, like a bronchitis or other infection, should be requested a different antibiotic. Yeah, Sherry, personally, I can just tell you, if it were me or a family member, right? If myself or a family member gets prescribed a quinolone antibiotic, I'm going to look askance at that because I know there's a relationship between the antibiotic and tendinopathy. Now that relationship is in a rare number of people. We're only talking about maybe 1 in 1,000 people that get that kind of response. But I'll probably ask for a different antibiotic simply because I know there's that relationship, meaning why take the risk if another antibiotic will work just as well? I think you guys should probably view it the same. Chronology, what is your take on vaccines causing CCI? We have no data that vaccines cause CCI at this point. We have so there's no information that links those 2 things. Again, I think what a lot of people do is they associate the concept that, for example, I've had 2 COVID vaccines. I had to get 2 to stay on hospital privileges. I had to get 2 to satisfy the Department of Health, et cetera, to be a doctor. So I got my 2. I never got any more after that for COVID, but I can tell you that with both of those, every old injury I ever had for that night, that first night of the pro-inflammatory component of that vaccine hurt. So, if I injured my knee jumping off a boat 10 years ago, my right knee, that right knee hurt. So it's the same thing with all of these, right? Is it possible that some of the vaccines could make something that was always clinically there come to the forefront? Sure, I'll buy that all day and twice on Sunday based on my own personal experience. But does that mean that the vaccine caused your CCI? It does not. All that means is that you already had a pro-inflammatory, high systemic inflammation in your body, metabolic syndrome, etc. You then added the vaccine on top of that. That bumped it up further. Every old injury you ever had, including to your neck, comes to the forefront. And then for whatever reason, that spirals from there. Doesn't mean the vaccine caused anything. All it means is that the vaccine may have tipped you over into making something that you always had symptomatic. Brain and cervical MRI, flexion extension, rotational CBCT, and a bunch of x-rays. Are those enough for you to get me diagnosed via teleconsultation? Could be. It's possible. Cervical MRI with flexion extension upright would be a key there. The flexion extension rotational CBCT could show things as well. And if that doesn't show it, you'd still need a digital motion X-ray to see as well. But we can certainly start with those and make a good go of it. But realize that that's not a complete set of information. So there would still be a false negative rate there. A false negative rate in medicine means that I have a bunch of tests. These tests look normal, but this one test that could be positive was never done. And so the first tests are false negative, meaning the person has the problem, but the tests that they have don't show it. Marcia, I feel better when I'm out as opposed to in, even if I hold for 2 months. Again, how you feel is what drives the bus, right? Not what someone sees or someone's telling you in or out. So how you feel drives the bus. Same answer. Amain, I'm confused. So if someone has CCI symptoms, no structural instability, what would be the solutions? Treat the upper cervical spine as the solution, meaning that it's important for everyone to understand craniocervical syndrome and craniocervical instability. Craniocervical instability, CCI, gets talked about a lot online. Craniocervical syndrome is actually much, much more common than CCI. Produces all the same symptoms. There is no instability, but the upper neck is causing the symptoms. So it could be a damaged C0, C1, C1, C2, or C2, 3 facet joint with no instability. It could be damage to one of the occipital nerves with no instability. It could be all sorts of things that could be damaged in the upper neck causing the same symptoms because it's the upper neck that causes most of these symptoms, but no instability. So you treat the structure that's damaged. Charmaine, have you seen more CCI and HEDS when the patient has the TNXB gene? Haven't looked at that to see if there's a relationship. So no, haven't. I can't say I've seen it, but I can't say we've looked at it either. Daniel, can oral traction through the mouth stretch the ligaments further if you have CCI? This happened to a person I know, and I had it done to myself, but AO luckily it didn't get worse. I guess, Daniel, you'd have to describe more about what you're discussing. I'm not familiar with people trying to do oral traction through the mouth. So I guess it would depend on how aggressive that oral traction was. Facebook users, you've often said that prolodextrose above C2 is very dangerous due to risk of the case. Fitting artery, does that mean the PRP is safer, or would both be a very bad outcome in case of injecting wrongly? No one should be injecting your upper neck without the availability of C-arm fluoroscopy with digital subtraction angiography readily available. The caveat could that, to that could be if you're just trying to hit a superficial structure, like an occipital nerve, then no harm, no foul, you can use ultrasound. But if you're trying to hit deep structures within the upper cervical spine, it's below the standard of care to do that without having C-arm fluoroscopy, contrast confirmation, and digital subtraction angiography. Now, if someone were using all those things and they inadvertently injected into an artery with hypertonic dextrose, that would be the most injurious to the artery because hypertonic dextrose works by killing local cells. That's literally its mechanism of action. It causes a local cell debridement, and then that causes a brief inflammatory response. Well, you don't want to kill artery cells because that obviously has other implications. PRP doesn't work that way. PRP works through growth factors. So it's going to be safer for that reason if it were inadvertently injected into an artery. Now, having said that, PRP can also have small clots within it. You can see platelet aggregates, and depending on the level of clots and platelet aggregates, that could cause other problems if injected into an artery. So I think on balance, PRP is probably safer than injecting hypertonic dextrose into an artery. But both of them could have their potential issues. Casey, an elongated linguine, yes, likely influenced by HEDS, causing excessive tongue movement and sleep apnea. Could regenerative treatment theory reduce laxity there? We don't treat it. Possible. I don't know that we know that that we know a lot about this at this point. So I'd have to say there's not enough information to know whether or not injecting your frenulum would help with sleep apnea. Christy, where can we find a list of anti-inflammatory meds that are not obvious NSAIDs or even supplements? Really, any natural anti-inflammatory drug. And I wouldn't worry so much about anti-inflammatory supplements. The two biggest ones out there would be curcumin and fish oil. Those work through the LOX pathway, so I'm not concerned about that. It's more the non-steroidal anti-inflammatory drugs, and that's an easy one. Just go on Google, type in list of NSAIDs, and the list will come up. It's super easy to do. Facebook user, if you have sleep apnea, could this interfere with the PICL procedure? Can this be an issue during? It can be, yes, but many CCI patients have mechanical sleep apnea in my direct experience. So the answer there is yes. Now, how often can it become a problem that, let's say, would reduce the number of injection targets we can get to safely? It's probably 1 in 20 patients who have a significant amount of mechanical sleep apnea, where if the priority is keeping the patient safe, and it always is, we may have to cancel doing this or that because the mechanical apnea is severe. So it's not common that it happens, but it can happen. And I'm going to start picking out some questions here just because we're getting to the last 10 minutes. I want to make sure I get to some good ones. Facebook user, how long after a PICL is one not supposed to bend his or her neck? We put no restrictions on that at all. I think it's a bad idea to restrict that, because the only way to legitimately restrict it is to wear a cervical collar. We want to get people out of cervical collars. I've seen so many patients put into cervical collars for CCI. In fact, there's one clinic that does this specifically. And what we end up with, the good news is that their overhang looks better, but they can't move their neck. That's why their overhang is better. So I've seen so many of these patients, they come in, they've been told don't move their neck. Some of them wear a collar to make sure they don't move their neck, and they're doing this for 1 or 2 or 3 years. And then we've got a new problem. Lost range of motion now becomes as big an issue as the CCI ever was. So they literally can't move. That's a really bad thing. We don't want to give patients that advice. Christine, have you seen a correlation or a connection between CCI and central sleep apnea? I don't obstruct, I just stop breathing sometimes. We have seen that correlation. I don't think anyone's ever published on it, but I can tell you it's substantial. The problem would be to publish on it. It's an observation we make during the procedure. Since we're working through the airway, we know if you've got central sleep apnea or mechanical sleep apnea. It's pretty common in CCI patients. The biggest problem is that you'd have to get a formal diagnosis on it. So the answer is yes, I observe it all the time. Charmaine, if the cranium is settled, is there any ligament injection can help relieve the brainstem compression? Yeah, Charmaine, it's usually not cranial settling that causes brainstem compression. So first thing I can tell you to do is to get that problem looked at with a different pair of eyes, meaning that if you've been placed in the vertical instability category, the question is it pure vertical instability that's causing your problem, or is it really just laxity between the skull and the Atlas. If it's the latter, you can be helped through injection therapy. If it's the former, you can't. But I think there's a lot of overlap between those two groups. Bo, does an albuterol inhaler have negative effect? What about using preventive inhalers for asthma? Albuterol inhaler should not have a negative effect. It's only the corticosteroid inhalers that become a problem, but not albuterol. Charmaine, thank you for encouraging critical thinking. Yes, please. We want critical thinking. We want people that do not look at the Facebook as their place for medical information. Listen, on Facebook, there's some great groups out there, like Dan Semrad's PICL group. He runs a tight ship, from what I hear. I'm not on it. I've never wanted to be on it, and I talk to patients. They really love that group. He doesn't allow the craziness to get on the group. But then there's the internet, right? You've got other Facebook groups that are out of control. You've got Reddit groups that are out of control, where you've got sellers who are literally on there inserting themselves into conversations to sell things like NAD+. So be very careful. Or another big one right now is to sell BPC 157, et cetera, et cetera. Bo, I also sometimes use triamcinolone for eczema. Is that something? Is negative effect from PICL? Would not be a net positive. The concern would be that it could cause a potential issue with the inflammatory response. So I think what I would do is probably stay off of that for 6 weeks before and 6 weeks after to be safe. Usually it's just a nuisance issue. I had eczema growing up as a kid. I still have a little bit. And, you know, it's a pain in the neck to itch, but in this case, you might have to. Let's see this next one. I just want to mention that you gave me non-PRP injections in my right shoulder, which have both inflammatory tendon tears, biceps tendon tear from me being Floxed. My shoulder's amazing. My physio was in shock when you did MRI about a year later. Yeah, so I think as I brought up before, we've seen a lot of patients who have been Floxed, who have had tendon injuries. PRP works very well in that crowd. I don't know why more of that crowd isn't getting PRP as a treatment. Because it works very well in my experience in those patients who have tendon injuries due to ciprofloxacin or quinolones. Are people sending in their questions via different route? We're live right now and I can see 4 messages. Yeah, so realize that this is, there's 3 different channels I'm on right now simultaneously. So they're sending in questions through any one of those 3 channels. So you may be on the channel that's not getting a lot of questions. Kelly Marr online, is there potential that symptoms associated with a functional neurologic disorder could actually be structural in nature caused by CCI? Yeah, Kelly, I don't like the diagnosis of functional neurologic disorder. My concern is that it's a black box that doctors tend to put people in where they don't know what's going on. So by all means, there's probably people in that black box who have craniocervical instability. It just was never diagnosed. So I try to stay away from that. I'm going to skip this next question because of the user. Is the live off Facebook now? We're not anonymous. Facebook users apparently show that way up on screen. Yeah, I don't know why. There's why it's showing up that way. Yeah, I don't know. It's on Facebook for sure. So maybe that's a new Facebook rule. Maybe it has to do with some arcane thing. I don't have a sense of it. Okay, guys, so we're in the last minute. Any last minute questions I can answer, put them in the chat right now. Again, today we talked about the use of quinolone antibiotics and ligament issues. Again, could be that a big study comes out next year, the year after that, or the year after that, that shows a really nice clinical correlation. We'll have to revisit this issue, but I try to use the peer-reviewed literature to guide what I do with patients. And so right now, the peer-reviewed literature is nowhere near at that point of showing a firm connection between taking quinolone antibiotics and something like CCI or even just something like garden variety ligament issues. But again, That's the wonderful thing about medical science is it evolves as more research comes to the fore. So thanks so much for all your great questions today. As I always say here, there are no bad questions. All questions generate discussion. I look forward to seeing you guys back next Sunday. This next Sunday, I'll be talking about a PICL certification program that I've been putting together to try to get doctors, number one, to do the screen. First, is the doctor capable of doing a PICL? And then number two is, have they done enough upper cervical work? And number three would be an extensive program to educate them on how to do the procedure. So there's going to be three pretty steep steps there to keep patients safe. And so we'll talk about that next week. I think someone just put something in here. If someone has instability as their entire cervical spine but only gets treatment up to C3, can this cause more instability up higher? If you mean by treatment, fusion, yes. If you mean just by correcting instability through injections, probably not. Okay, guys, thanks so much for watching. Have a great day. Look forward to seeing you guys here next week, and have a wonderful week. Thank you.